Welcome to the Deep Dive Ortho. We're the show that gets into the detail of complex medical topics, giving you, well, the essential insights you need to stay right at the forefront of your practice. Today, we're diving deep into an area of occupational health that I think is often underestimated, but it's critically important. Hand-arm vibration syndrome, or HAVS. It's one of those conditions that can creep up over years, quietly impacting a worker's life. And it really demands our sharpest diagnostic and management skills as medical professionals. It's a huge topic for mid-senior medical professionals, wouldn't you say? Not just because it's common, but also because diagnosing it can be, well, quite a challenge. Now, to guide us through the intricate world of HABS, we're incredibly lucky to have Professor Mo Imam with us today. He's a leading expert in occupational health and orthopedics. His expertise is really going to help us navigate the nuances of this condition and deepen our understanding. So, our mission today is pretty clear. We want to comprehensively explore HAVS. We'll look at everything from the underlying causes, the varied clinical pictures you might see, right through to the diagnostic hurdles, effective treatment, and the bigger picture for patient care and workplace policy. Think of this as a necessary update, really, for well-informed practice, equipping you with the insights to better serve your patients. So let's get started. Okay, let's unpack this. Hand-arm vibration syndrome, HAVS. It's a term we hear a lot in occupational medicine, but maybe its full scope isn't always immediately clear. Before we get into the weeds, could you give us a clear definition, perhaps touch on its historical name too? How did we get to calling it HAVS?
Yes, certainly. So at its core, hand-arm vibration syndrome, or HAVS, is a condition primarily affecting the nerves, blood vessels, muscles, and joints. Where? In the hand, wrist, and arm. And the cause is fundamental prolonged, regular exposure to vibration. Vibration transmitted directly from power tools into the worker's hands. Historically, you're right, it was probably better known as vibration white finger, or VWF.
Yes, VWF. I remember that term well.
Exactly. But that name was updated, quite deliberately, to HAVS. Why? To reflect the much broader range of potential effects. It covers issues far beyond just fingers going white, that digit blanching VWF describes. It brings in the neurological and musculoskeletal problems, too. And it's crucial we recognize HAVS now as a widespread, formally acknowledged industrial disease. It affects tens of thousands of workers, particularly here in the UK.
That broader understanding is absolutely vital, isn't it? Especially thinking about patients who might present without the classic white finger. So, what's the current prevalence we should be aware of? And which jobs, which occupations should really put us on high alert? I've seen some figures that are, well, quite striking.
Yes, the figures are compelling. Reports suggest, on average, maybe 1 in 10 people who regularly work with vibrating tools could develop HAVS.
1 in 10, that's significant.
It is. But among workers who are definitely exposed, the prevalence reported can vary hugely. Sometimes as low as 6%, other times, in specific highly exposed groups, it can be up towards 100%. The average is often quoted around 50%.
Wow, 100% in some groups.
Yes, it highlights the massive variability in risk depending on the tools, the hours, the industry. When you think high-risk jobs, it's often what you'd expect. Construction, forestry, quarrying, building, carpentry, mechanics, general laboring.
Lots of heavy tool use there.
Yeah, exactly. Roles using rotary and percussive tools, daily grinders, jackhammers, impact wrenches. They definitely carry the highest risk.
Yeah.
But what often surprises clinicians is the link with dentistry.
Dentistry, really?
Yes. While a single use of a dental handpiece might not seem like much exposure in real time, a long history of frequent use of these, lower magnitude tools has been linked to HAVS in dental workers. And interestingly, sometimes it's seen combined with other factors, like a high body mass index, which might influence things.
That's fascinating. So it's not just the big, heavy industries.
And not at all. And then there's the gender disparity. It's much higher in men. UK estimates are about 9 to 1, men to women. Swedish estimates even higher, 11 to 1.
And that's mainly down to historical work patterns.
Primarily, yes.
Yeah.
Tool use in those high-risk industries has historically been male-dominated. But, and this is vital, women are affected too. We mustn't overlook them. Any patient with suggestive symptoms, regardless of gender, needs a thorough occupational history.
That point about dentistry really challenges our assumptions, doesn't it? But HAVS isn't just one thing. We hear vibration white finger, but you said it's broader. Could you help us unpack that triad of symptoms, the neurological, vascular, and musculoskeletal? Maybe walk us through a typical sort of presentation where knowing all three is key.
Absolutely. Thinking of HAVS as this constellation of symptoms, not just one thing, is vital for assessment. It typically presents with that triad: peripheral, neurological, vascular, and musculoskeletal issues. So let's start with the peripheral neurological symptoms. Usually, workers first report tingling and numbness. Often it's intermittent, just affecting the fingertips.
Okay, pins and needles, that sort of thing.
Yes, exactly. But if the exposure carries on, these symptoms can unfortunately become continuous, and that leads to problems like reduced fine motor coordination, poor dexterity, weakened grip strength, typically worse in the dominant hand, which makes sense, reflecting the main exposure.
And that sounds like it could easily be confused with other things.
Absolutely. That's the diagnostic challenge, distinguishing these from, say, diabetic neuropathy. And crucially, they look a lot like carpal tunnel syndrome, CTS. There's significant overlap. You see, the nerve damage in sensorineural HAVS mainly happens right at the nerve endings, the smaller nerves, the mechanoreceptors in the fingertips, whereas in CTS, the damage is from compression of the median nerve up at the wrist. Different location, similar symptoms sometimes.
Right. And the vascular side, that's the white finger bit.
That's the classic vascular part, yes. Commonly known as occupational Raynaud disease or vibration white finger. It's characterized by that local finger blanching the fingers go white due to vasospasm of the tiny skin ventricles.
Triggered by cold.
Classically, yes. Triggered by cold exposure, either the environment or just touching cold objects. And during an attack, you see that typical triphasic color change, white, then sometimes blue, and finally red as the hand rewarms. That rewarming phase is often quite painful, throbbing.
How does that differ from primary Raynaud's?
Good question. Primary Raynaud's often affects both hands, sometimes feet too, quite symmetrically, and it can be linked to other conditions. Occupational Raynaud's, though, tends to be asymmetrical, focused on the hand that's been exposed to the vibration, and with continued exposure, the attacks usually get worse, cover more of the finger, last longer, happen more often. In rare, severe cases, you might see cyanosis, or even very rarely, fingertip necrosis. It's also worth noting the vascular symptoms generally take longer to appear than the neurological ones. There's a longer latency.
Okay, so neurological, vascular. What about the musculoskeletal part?
Right, the musculoskeletal component. This typically involves persistent aches and pains in the hands and lower arm, often described as a deep sort of aching discomfort. It can really impact hand function, weakened grip strength, reduced ability for tasks needing fine dexterity. And prolonged vibration can also predispose people to specific conditions. Things like early onset osteoarthritis in the wrist and hand joints, bone cysts forming, especially in the carpal bones, and various tendinopathies in the arm because of the repetitive strain from tool use.
So it's quite a mix.
It is. And understanding that a patient might have any one of these, or a combination, even without the classic white finger, is really key for catching it early.
It's clear this isn't something that just appears overnight. It's chronic. It progresses. How does AVS typically evolve from those initial symptoms? And are there recognized staging systems to help us gauge severity, both clinically and, I suppose, for medico-legal reasons?
You've hit on a key point. It is cumulative and progressive. What starts mild and intermittent can definitely worsen and become permanent if exposure continues. The mean latency period, the average time from first exposure to symptom starting, is typically around 6 years.
6 years? That's quite a delay.
It is. And to help us understand this progression and severity both in clinic and for, as you say, medico-legal assessments, we use staging systems. The most widely recognized is the Stockholm Scale.
Ah, the Stockholm Scale. Could you break that down for us?
Yes, it gives a clear framework. Stage 0 is no symptoms. Basically, no numbness, no vibration issues, normal hand function. That's the baseline. Then stage 1, mild. Here you typically see occasional numbness, just in one or more fingertips. Interestingly, tingling isn't usually a big feature at this stage. It's more a dulling of sensation.
Just numbness, okay.
Then stage 2, moderate. Now, the numbness can be occasional or continuous. There's a noticeable loss of sensation, and critically, it affects not just the tips, but the middle parts of the fingers too. Clinically, this might mean difficulty picking up small things, coins, buttons, or just general clumsiness with fine tasks.
That sounds quite disabling already.
It can be. Moving to stage 3, severe. Here you have frequent or even constant numbness, a significantly reduced ability to feel textures or handle small objects. This sensory loss affects most parts of the fingers. It causes noticeable clumsiness and can really impact someone's ability to do their job.
And the final stage?
Stage 4, very severe. This has the same profound sensory loss as stage 3, but it's compounded by trophic changes in the fingertips.
Trophic changes, what does that mean practically?
Visible skin or tissue changes. Things like skin thickening, maybe ulceration, changes in nail growth. In extreme, though thankfully rare, cases, this stage can lead to critical circulation problems, potentially even loss of digits. And one other really important thing to remember, symptoms can sometimes develop months or even years after someone stops working with vibrating tools.
Years later. Wow.
Yes, it really highlights the long-term insidious nature of it and why taking a very thorough occupational history, looking back many years, is absolutely crucial.
So what does this all mean for daily practice? Clearly, the core issue is the vibration itself, but can you break down the specific characteristics of vibration exposure that actually cause HAVS? It's not just using a vibrating tool, is it? There must be more to it.
You're absolutely right. It's much more nuanced. Understanding the mechanics is key to understanding causation. HAVS develops from the vibration transmitting from the tool into the hands and arms. Over time, this repeated microscopic trauma causes damage to those delicate tissues, the nerves, blood vessels, muscles, joints we talked about.
Microdamage building up over time.
Precisely. And several factors influence this. First, prolonged tool use and high vibration levels are the direct culprits. The risk spans a broad frequency range, maybe 5 to 2,000 hertz. But the highest risk for the fingers specifically is usually between 50 and 300 hertz. For the whole hand and arm, risk is often noted between 8 to 16 hertz, according to the ISO standard, although newer research suggests medium and high frequencies also significantly raise the risk. So it's a broad spectrum.
Okay, so frequency matters. What else?
Second, grip force. This plays a huge, often overlooked role. Holding tools tightly, which you often have to do for control, dramatically increases how much vibration gets transmitted into the hands and arms.
Right, the tighter you grip, the more vibration gets through.
Exactly. It amplifies the energy transfer, increasing the risk. It's not just the tool's output, it's how the worker interacts with it. And third, the material being worked on. Its density and texture can significantly influence the vibration effects.
How so?
Well, working on harder materials like concrete or dense wood naturally creates more vigorous, more damaging vibrations that get fed back to the worker compared to softer materials, even using the same tool. The material's resistance dictates the feedback.
That makes sense. The tool itself is a major factor, clearly. But it's rarely the only thing at play, is it?
What about the environment? Workplace practices, what else contributes or makes things worse?
You're spot on. It's multifactorial. Environmental and workplace factors are critically important. They can contribute to the risk or aggravate existing symptoms. Firstly, cold work conditions. Cold is a massive exacerbator. It directly triggers that vasospasm in the fingers, the Raynaud's phenomenon.
Makes the vascular symptoms worse. Precisely. Constricting blood vessels reduces blood flow, making tissues more vulnerable to vibration damage and slowing recovery. So, keeping hands warm is a crucial preventative step. Imagine a construction worker on a cold, windy day. That combination is synergistic risk.
Yeah, you can picture that easily.
Secondly, lack of breaks. Continuous exposure is far more damaging than intermittent use. Not having enough breaks means the affected tissues don't get adequate recovery time. Microdamage accumulates, accelerating the condition.
So shorter, more frequent breaks are better.
Much better. Short breaks, say at least 10 minutes away from the vibrating tool, are far preferable to long, uninterrupted stretches of exposure. It's about letting the body recover. And thirdly, poor workstation design. This might seem indirect, but it's significant. Bad ergonomic design can lead to awkward postures, forcing workers to grip harder or hold their hands and wrists unnaturally. This increases the load on their hands, wrists, arms, which in turn can heighten the risk or worsen existing HAVS symptoms by adding to the stress on the musculoskeletal and neurovascular systems. It's the overall ergonomic burden, not just the vibration.
And of course, not everyone reacts the same way. It's easy to just look at the tool someone uses, but biology is rarely that simple. Does individual susceptibility play a big role, and what other non-work factors should we be asking patients about?
You've hit on a crucial point there. Individual susceptibility is a critical piece of the puzzle. It helps explain why not everyone exposed to similar vibration levels gets HAVS or gets it at the same rate. Beyond the job itself, several non-work risk factors and individual predispositions can really influence who develops HAVS and how it progresses.
Like genetics.
There's an acknowledged role for genetic predisposition, yes. Some people are just biologically more likely to develop vibration injury. But smoking, that stands out as one of the most critical and importantly modifiable aggravating factors.
How does smoking make it worse?
Nicotine directly causes vasoconstriction narrowing of the blood vessels. This significantly cuts blood flow to the fingers. It directly worsens the vascular symptoms of HAVS, makes Raynaud's attacks worse, and dramatically slows any potential recovery. In fact, smokers with HAVS are twice as likely to have severe circulatory problems compared to non-smokers. It's something we absolutely have to counsel patients on.
Twice as likely. That's huge. What else?
We also need to ask about exposure outside work. Hobbies, DIY. Many people use vibrating tools in their leisure time. Gardening tools like trimmers, leaf blowers, power tools for home projects.
Right. It all adds up.
Exactly. These exposures, even if they seem small individually, add to the total lifetime vibration dose. They can definitely contribute to symptoms starting or getting worse. Then we must be cautious about medication use. Certain drugs can worsen peripheral circulation.
Such as?
Common ones include beta blockers, often used for high blood pressure or heart issues. Over-the-counter decongestants are another. They often contain adrenaline-like substances that constrict blood vessels. Certain ergot derivative migraine medications should also be avoided. And interestingly, in some women, the oral contraceptive pill can sometimes exacerbate HAVS symptoms, though that's less common. A full medication review is important.
Good point. And pre-existing conditions?
Yes, pre-existing medical conditions are crucial. Things like peripheral vascular disease, rheumatoid arthritis, cold hemagglutination syndrome, or diabetic polyneuropathy can either mimic HAVS symptoms or worsen them. This complicates diagnosis and management. So a thorough systemic medical history is paramount to rule these out or identify them as complicating factors.
You mentioned the neurological symptoms earlier, which immediately brings carpal tunnel syndrome, CTS, to mind. I know from clinic how tricky differentiating them can be. How often do these conditions actually coexist rather than just one mimicking the other? And what's that first critical question we should ask ourselves when a patient presents with these overlapping symptoms?
That diagnostic minefield description is very apt, and yes, it's a common scenario. The overlap between HAVS and CTS is significant, and they very frequently coexist. HAVS can mimic CTS symptoms closely, making differentiation a real hurdle. The primary challenge comes up especially when, say, a male worker with a long history of using vibrating tools comes in with what look like classic CTS symptoms. In that case, the very first critical question we must ask is, could this also be HAVS or even primarily HAVS rather than just CTS?
So don't just jump to CTS.
Yeah, exactly. It's absolutely paramount to strongly consider HAVS, or a co-diagnosis of both, before attributing everything solely to CTS. Both conditions, as you say, present with similar sensorineural symptoms, numbness, tingling, often in similar finger patterns. But the key distinction anatomically is the primary site of nerve damage. In HAVS, it's typically the nerve endings and smaller nerves at the fingertips, damaged by direct vibration. In CTS, it's the median nerve being compressed at the wrist. That compression causes the damage, affecting the palm and potentially the whole digits. Recognizing this difference in pathology location is the first step in untangling them, but it's not always simple.
So that first question is critical. Could this be HAVS? Then, moving into the clinic room, what specific historical clues or physical exam findings can help us unpick this diagnostic knot? Differentiate between HAVS and CTS. This is where the clinical detective work really starts, isn't it?
Precisely. This is where detailed history taking and meticulous examination become our most powerful tools. Let's break down the key differentiating features. First, think about pain characteristics. In sensorineural HAVS itself, pain isn't generally a primary feature. When pain does occur in HAVS, it's typically during that rewarming phase after a Raynaud's attack, post-blanching, often described as throbbing or aching.
Whereas CTS often involves pain.
Exactly. Pain is quite common in CTS, frequently felt around the wrist, throughout the hand, maybe extending up into the lower forearm. And crucially, nocturnal pain and paresthesia, pins and needles, waking the patient up at night, that's highly characteristic of CTS.
Waking from sleep is a big clue for CTS then.
A very big clue. While it might occasionally be reported in HAVS, it could often reflect diagnostic confusion rather than being a direct HAVS symptom. So significant night pain in the hand should definitely make you lean towards CTS.
Okay. What about the pattern of numbness, the sensory distribution?
Good point. For sensory distribution, in HAVS, symptoms like tingling and numbness are typically focused right at the fingertips, affecting the nerve endings there. With CTS, the sensory symptoms can affect the palm and the whole length of the digits supplied by the median nerve. Importantly, CTS symptoms can sometimes extend proximally into the lower forearm. And it's vital to know the sensory distribution of CTS isn't always strictly by the textbook median nerve pattern. There can be variation.
So forearm numbness points away from HAVS.
Yes, reduced sensation in the lower forearm wouldn't typically occur in HAVS, but it can in CTS. Also, while the little finger can be affected in CTS sometimes, if the index finger is also involved, suggesting broader neuropathy. If the little finger is clearly spared sensory changes, that tends to support a CTS diagnosis.
Right. What about muscle weakness or wasting?
Okay, motor impairment and atrophy. Both conditions can lead to reduced grip strength and dexterity because of nerve issues or pain. But a critical differentiating sign is the thenar atrophy. That's the wasting of the muscle bulk at the base of the thumb, particularly the abductor pollicis brevis muscle.
Wasting of the thumb muscle.
Yes, if that's present, it's highly suggestive of CTS, and it does not occur in HAVS.
Yeah.
It's a very important physical sign to look for. It points directly to median nerve compression.
Okay, that's a key one. And finally, Raynaud's.
Right, Raynaud's phenomenon.
Yeah.
Occupational Raynaud disease, or vibration white finger, is a primary vascular part of HAVS. Now, Raynaud's phenomena can happen in CTS, but it's much less common and usually presents differently. Nonspecific color changes or blanching, affecting the palm or the back of the hand. Those are not features of HAVS. HAVS blanching is typically digital in the fingers. Increased sensitivity to cold, but without actual color changes, might be a precursor to HAVS, but shouldn't be considered diagnostic on its own. It's subtle, but points towards the underlying pathology. These clinical distinctions, though sometimes fine, are our first line of defense.
Given these subtle, often overlapping clinical pictures, what diagnostic tools do we actually have? And maybe more importantly, what are their limits when we're trying to definitively diagnose HAVS or tell it apart from CTS? It sounds like we're not looking for a single magic bullet test here.
You're absolutely right. There is no single magic bullet test for HAVS. Often the diagnosis is primarily clinical, based on that comprehensive history of symptoms and exposure, combined with a thorough physical exam. But a major limitation straight away is the absence of a gold standard objective test for HAVS. Unfortunately, different authors, different clinicians use varying tests or sometimes no specific objective tests at all for AVS. This reflects that lack of a universally accepted definitive diagnostic tool, which makes diagnosis challenging, relying heavily on clinical judgment.
So what tests do we use?
We do employ a range. For vascular tests, things like Allen's test, cold provocation tests, cold challenge plethysmography, Doppler ultrasound, radioactive clearance methods to measure digital blood pressure and flow. Thermography is sometimes used, too, to look at skin temperature patterns.
But are they reliable?
Well, a critical limitation here is that the conditions for cold stress tests, especially cold provocation, aren't standardized across different labs. This really impacts their validity and reliability, makes comparing results difficult.
Okay. And for the neurological side?
For neurologic tests, we use bedside tests like light touch, pinprick sensation, thermal threshold testing, vibration perception threshold, two-point discrimination, plus nerve conduction studies, NCS, electromyography, EMG, and provocative tests like Tennell's and Phelan's. But here's a crucial point from the literature. No bedside test could reliably distinguish HAVS from CTS definitively.
Not even nerve conduction studies. I thought they were the gold standard for CTS.
They are widely considered the gold standard for diagnosing CTS, yes, because they objectively measure median nerve function. But they're not infallible. Reported sensitivities are typically around 74% to 78%, which means they might miss about a quarter of CTS cases, a significant false negative rate.
A quarter. That's quite high.
It is. Plus, NCS mainly tests the large diameter nerve fibers. These only make up about 20% of the peripheral nerve. Now, it used to be thought that small fiber damage, the myelinated delta and unmyelinated C fibers, wasn't really a feature of CTS. But recent evidence suggests it might occur in severe cases, possibly explaining things like cold sensitivity. However, testing small fibers isn't generally useful for detecting typical CTS. And another point, vibration perception thresholds can be raised in both CTS and HAVS, so it's nonspecific doesn't really help differentiate.
So what's the best approach then, given these limitations?
Our best approach has to be an integrated one. By doing tests at both the receptor level like thermal esthesiometry and vibrotactile thresholds, and at the nerve trunk level at the wrist, using NCS, we can try to differentiate the level of damage. This can give strong clues about whether symptoms are more likely HAVS peripheral, small fiber issues, or CTS nerve trunk compression. But, and this is key, we always have to stress that the results of these tests are considered within the bigger picture. The patient's symptoms, clinical signs, and their detailed occupational history. They're pieces of the puzzle, not standalone answers. So ultimately, without that magic bullet, our most powerful diagnostic tool remains our clinical acumen, meticulously combining history, exam, and interpreting tests within that unique patient context.
That emphasis on integrating all the data makes perfect sense, especially since HAVS and CTS symptoms seem to overlap so often. So it sounds like diagnosis is less either and more about spotting an and. Is it common for HAVS and CTS to just coexist rather than one simply mimicking the other?
You've really hit on a profoundly important point there. It's not just common. It's a frequent clinical reality. HAVS and CTS can, and often do, coexist. This is a critical take-home message. When we're assessing, say, a male patient, especially one with a significant history of using vibrating tools, who presents with what look like CTS symptoms.
We have to think HAVS too.
Absolutely. It becomes paramount to consider a co-diagnosis of HAVS. This isn't just academic. It has critical implications. Why? Because treatment strategies might differ. What you do for CTS might not be enough if HAVS is also there. And crucially, it affects the prognosis for returning to work. Recognizing this coexistence is vital for truly holistic patient management and for guiding the right occupational health interventions. We have to think broadly, look at the whole picture occupation clinical history, not just try to fit them neatly into one diagnostic box.
So we've navigated the complexities of diagnosis, which clearly is a major hurdle. Now let's talk management. If we have a patient with established HAVS, what's our approach? What can we realistically do to mitigate progression or improve their symptoms?
This is a vital question, and it's important to be realistic upfront. Treatment for established HAVS, especially in severe cases, is often ineffective at reversing the damage that's already occurred.
Really? That's quite sobering.
It is, and it really underscores why prevention and early intervention are so incredibly important, which we'll come on to. The absolute critical part of treatment, reflecting that direct dose-response relationship of HAVS, is cessation of exposure.
Stopping the vibration completely.
Completely. Removal from all vibration exposure, not just at work, but leisure activities too. Now, in the early stages, if exposure stops and the person stops smoking, the condition may be reversible, or at least its progression halted. But in advanced stages, even if they stop exposure completely, the condition usually doesn't improve. And sadly, it may continue to progress, potentially leading to irreversible loss of hand function, or, very rarely, fingertip necrosis from critical ischemia.
So stopping exposure is non-negotiable, especially if symptoms are bad.
Absolutely. The UK Health and Safety Executive and the US NIOSH both strongly recommend that workers with blanching the white finger extending beyond the fingertip, proximal to the distal phalanx, on one or more fingers, should cease work with vibration entirely. It's a crucial intervention to prevent further irreversible harm.
Okay. What else is key?
Smoking cessation. This is another incredibly important factor we must actively counsel patients on.
We mentioned it as a risk factor.
Yes, and it's just as critical in treatment. Smoking causes narrowing of arteries, significantly cutting blood flow to the fingers. This directly aggravates the vascular part of HAVS, makes Raynaud's attacks more frequent and severe, and dramatically slows recovery. Smokers with HAVS are twice as likely to have severe circulatory problems. It's a key modifiable factor.
Right. And managing temperature.
Yes, temperature management is key. Advise patients to keep their core body temperature high and their hands warm. Actively avoid cold exposure. This helps reduce the frequency and severity of blanching attacks. That means warm clothing, heated workspaces if possible, avoiding touching cold objects directly.
What about those anti-vibration gloves you see?
Ah, yes. It's a common misconception. They offer significant vibration protection. Scientific studies show few, if any, genuinely reduce vibration effectively. Some might even amplify vibration at lower frequencies, below 100 hertz, which is dangerous.
Oh, they're not the answer.
Their main benefit, and it's a crucial benefit, is keeping hands warm and dry. That helps prevent cold-induced vascular attacks. Proper selection by an occupational health expert is vital, though, to avoid gloves that reduce sensation or force a tighter grip, which could actually make things worse.
Okay. Are there medications that can help?
In terms of pharmacological interventions, calcium antagonists like nifedipine are often considered for severe Raynaud's symptoms.
How do they help?
They dilate blood vessels, improving digital circulation. A trial of, say, 10-20 milligrams per day for a couple of weeks is common. They've shown success in trials, especially in older patients. But crucially, we must advise patients to avoid medications that can worsen finger circulation. We mentioned beta blockers, over-the-counter decongestants with adrenaline, certain ergot migraine pills, and potentially the contraceptive pill in some women. A medication review is essential.
Any other management points?
For workers with severe sensory loss, injury avoidance is paramount. Reduced sensation means they might not notice cuts, burns, etc. So recommend they visually protect their hands and inspect them regularly for any skin breaks or trauma. And finally, it's interesting that the literature review didn't really mention specific physical therapies as a direct proven treatment for HAVS itself. The focus stays heavily on stopping exposure and managing symptoms.
That reality check on treatment effectiveness really drives home the point prevention is where our efforts truly need to be focused. Given the difficulties in treating established HAVS and the risk of irreversible damage, prevention is absolutely paramount. What practical, effective steps can workers themselves take to significantly cut their risk beyond what their employer might do?
Prevention is indeed the cornerstone, given how hard HAVS is to reverse. And workers themselves play a crucial role. Empowering them with this knowledge is key. First, tool handling. Workers should be trained to hold tools as loosely as possible while still keeping control. Avoid that excessive grip force as it transmits more vibration.
Looser grip, less vibration transfer.
Exactly. And encourage them to frequently change their hand positions on the tool. This distributes the load across different parts of the hand and arm, preventing localized overload. Second, tool maintenance. Vital. Well-maintained tools prevent avoidable increases in vibration and work more efficiently.
Like keeping blades sharp.
Precisely. Blunt or damaged concrete breaker chisels or grinding wheels mean tasks take longer, meaning more exposure. Regularly sharpening chainsaw teeth is another specific example. Good maintenance is less hazardous tool. Third, tool selection and correct use. Always use tools correctly as the manufacturer intended, and choose the right tool for the job. The aim is to avoid needing to grip too tight or use the tool longer than necessary. For example, using a diamond-tipped rotary drill bit for brickwork instead of a tungsten-tipped hammer action, one can massively reduce vibration for the same task.
Makes sense. What about breaks and work patterns?
Fourth, work schedules and breaks. Absolutely crucial. Workers should limit their total vibration exposure time, plan work to avoid long, continuous stretches of vibration. Several shorter periods with non-vibrating tasks in between are much better.
Those 10-minute breaks you mentioned.
Yes, take regular breaks of at least 10 minutes away from the tool to allow recovery. Employers can help here by organizing rotas for continuous tool use, limiting individual exposure times, especially keeping people out of the high-risk exposure bands. Task rotation, where workers switch between vibration and non-vibration tasks, is a practical solution. Fifth, personal protection. Specifically, keeping hands warm and dry while working, especially in cold weather. This promotes good blood circulation, helping protect against vibration white finger by reducing gasospasm. And finally, that crucial lifestyle factor again, avoid smoking. As we've discussed, it hits blood flow hard and makes HAVS symptoms much worse. These practical steps, if workers consistently apply them and employers support them, can dramatically cut the risk of developing this debilitating condition.
Now, this isn't just a physical problem, is it? We're increasingly recognizing the huge psychological toll that chronic occupational conditions like this can take. What are we learning about the mental health impacts of HAVS, and how should that change our approach to patient care? It feels like something we as clinicians need to be much more aware of.
You're absolutely right. The psychological impact is substantial and often overlooked if we only focus on the physical. But it's an area where our understanding is growing rapidly. Research clearly shows that many workers with HAVS experience poor mental health outcomes. For instance, one study found a significant number commonly felt depressed, 27%.
Over a quarter.
Yes. And even more starkly, 35% reported little interest or pleasure in doing things, a key sign of anhedonia. And 28% had clinically significant anxiety symptoms. It paints a grim picture of the mental health burden alongside the physical symptoms.
Is there a link between how bad the physical symptoms are and the mental health impact?
A very direct link, it seems. A crucial finding is that the Quick Stay score, that's a validated measure of upper limb function and disability, was identified as the only significant predictor of poorer psychological outcomes, looking at things like SF-12 mental component and GAD-2 anxiety scores.
So worse function equals worse mental health.
Essentially, yes. It suggests a direct correlation. The more functionally impaired someone is by HAVS, the higher their chance of experiencing significant mental health distress. Qualitative studies really bring this to life, highlighting experiences like loss of identity, especially for those whose work is central to who they are, poor self-perception, feeling embarrassed about not being able to do things, withdrawing from social activities, losing independence, and strong feelings of anger and anxiety.
That sounds devastating for quality of life.
It truly is. These aren't just side effects. They deeply impact a person's overall well-being, self-worth, social life. And it's worth noting, the mental health impact of HAVS seems similar to what we see with other chronic occupational conditions, musculoskeletal disorders, psychosocial stress at work, asbestos exposure, even unemployment. It puts the toll of HAVS into a broader but equally concerning context. Chronic occupational illness often carries a heavy psychological price.
So what are the implications for us? For policy?
Well, clinically, the findings suggest the Quick Day score could be a useful quick screening tool. It could help identify workers with HAVS-related disability who are more likely to have mental health issues. Therefore, it's imperative that employers and healthcare providers like us pay much more attention to these psychological effects. We need to move beyond just physical treatment. We need to consider tailored policies and interventions that address not only the physical side, but also the crucial mental health needs of affected workers. It's really a call for truly holistic, compassionate care that sees the whole person.
That holistic approach is clearly vital. So zooming out a bit, what does all this mean for employers and the broader regulatory landscape? There are definitely clear legal responsibilities here, aren't there? Especially given some of the fines we hear about.
Absolutely. Employers have clear legal and ethical obligations regarding HAVS, and ignorance is no defense here. They are legally required to protect workers from excessive vibration exposure. And failure to do so has resulted in significant fines, serving as a stark warning.
You mentioned some examples.
Yes, Rotherham Metropolitan Borough Council was fined £60,000. Plymouth City Council faced a £200,000 fine for related hand and wrist conditions that stemmed from inadequate vibration controls. These cases highlight the serious consequences of noncompliance, not just for worker health, but for the organizations too.
So there's a strong legal framework.
Yes, in the UK, the Control of Vibration at Work Regulations 2005 is the primary legislation. It sets clear action values and exposure limit values that employers must adhere to. Furthermore, HAVS is formally recognized as an industrial disease, prescribed disease A11 under the UK's Industrial Injuries Disablement Benefits Scheme, the IIDB. This provides non-contributory, no-fault benefits for disablement from work-related conditions. And in severe cases, HAVS might even be legally classed as a disability under the Equality Act 2010.
Which means employers have to make adjustments.
Exactly. It obligates employers to make reasonable adjustments for affected workers, perhaps helping them continue working or return to suitable duties. The legal implications are quite far-reaching, so the core responsibilities for employers are fundamental.
Yeah.
Identify who's at risk, rigorously assess that risk, measuring or estimating exposure, and then implement effective control measures to reduce exposure as low as reasonably practicable. It's not just about ticking boxes, it's about preventing often irreversible harm.
Beyond just meeting the legal minimums, what practical, proactive steps should employers be taking to really get a grip on HAVS risk in their workplaces? It's got to be more than just handing out gloves, surely.
Oh, absolutely. It requires a comprehensive, proactive strategy, way beyond just PPE. Employers should start with a detailed action plan, tackling the highest risk tasks first. Firstly, look for alternative work methods. Actively seek ways to eliminate or significantly reduce vibration exposure altogether.
Like using different machines.
Exactly. Using a breaker attachment on an excavator instead of a handheld breaker for demolition. Or choosing a rotary diamond-tipped drill bit instead of a hammer-action one for brickwork. They should consult trade associations, industry contacts, equipment suppliers to find best practices, mechanized solutions, automated options that take the worker out of the direct exposure loop.
Okay, eliminating is best. What if you can't?
Then equipment selection is crucial. Choose equipment that's suitable, efficient, and critically, has the lowest possible vibration emission for the job. This needs a proactive approach to buying. Limit the use of high vibration tools whenever you can. Have a formal purchasing policy for replacing old kit.
What should that policy include?
Talking to suppliers, comparing vibration data, manufacturers often provide this, asking about specific use cases and training needs, and importantly, involving employees in selecting tools. Purchasing staff need training on vibration issues too. For instance, knowing how to operate a breaker with vibration isolating handles correctly is vital to get the benefit. Just having the tool isn't enough if it's used wrong.
Right. And workstation design.
Thirdly, improve workstation design. Minimize loads on hands, wrists, arms caused by poor posture. Use things like jigs, suspension systems to reduce the need for tight gripping of heavy tools.
Like suspending a heavy grinder.
Exactly. Suspending a heavy grinder from a counterbalance for repetitive work reduces strain significantly. Fourth, implement robust maintenance programs. Prevent avoidable increases in vibration. Follow manufacturer servicing recommendations. Replace blunt or damaged consumables, chisels, grinding wheels promptly to maintain efficiency and keep exposure time down. A blunt tool means longer use, often more force, more vibration. Regular sharpening of chainsaw teeth is another prime example.
Makes sense. What about work patterns again?
Fifth, control work schedules. Limit the time employees are exposed. Plan work to avoid those long, continuous periods. Shorter bursts are always better. Use employee rotas for continuous tool use to limit individual exposure, keeping people below high-risk levels. Team-based task switching is a practical way.
Okay. And clothing.
Sixth, provide appropriate protective clothing. mainly to keep employees warm and dry, especially in cold, to encourage good circulation and help prevent vibration white finger. But reiterate, anti-vibration gloves are not reliable for vibration protection itself. Their role is largely thermal.
And finally,
Monitoring and review. It's ongoing. Regularly check control programs are working and still relevant. Keep communication open with managers, supervisors, employees, union reps about vibration issues. Encourage symptom reporting. And crucially, review health surveillance results with health providers to see if controls are effective and if changes are needed. It's a continuous improvement cycle.
now, beyond the typical HAVS symptoms, are there any more severe, perhaps less common complications, musculoskeletal or vascular, that we should be aware of? Things that can arise from prolonged vibration. It's important to know the full potential range of harm.
Yes, indeed, there are more severe, albeit less common, complications directly linked to prolonged vibration that we should certainly be aware of. They represent the extreme end of the harm spectrum. One condition is Kienbuck's disease. This is essentially osteonecrosis, bone death, of the lunate bone in the wrist.
Bone death in the wrist, how is that linked to vibration?
It's thought to be a consequence of repeated microtrauma from vibrating tools. It's predominantly seen in jobs with high-impact vibration construction, mining, metallurgy. Diagnosis is usually via MRI, which shows the avascular necrosis, the dead bone. It can also show associated scaphoid fractures. Treatment varies hugely depending on the stage, from simple immobilization early on to complex surgery like osteotomy to change wrist mechanics, revascularization to restore blood supply, fusion procedures, or even removing wrist bones carpectomy in advanced cases.
Is it officially recognized as work-related?
While the International Labor Organization doesn't directly classify Kienbuck's as an occupational disease itself, HAVS is unequivocally recognized as a significant risk factor for developing it. So it should definitely be on our radar for patients with the right occupational history. Another, even rarer but important complication to consider in the differential for upper limb pain, swelling, weakness in exposed workers is Paget-Schroeder syndrome.
What's that?
It involves primary thrombosis, a blood clot in the axillary or subclavian vein up near the collarbone, often due to repetitive overhead arm movements and compression. While not exclusively vibration-related, it can be exacerbated in physically demanding jobs involving tool use. And it's fascinating, just as an aside, to contrast this harmful high-magnitude hand-arm vibration with low-magnitude whole-body vibration therapy.
Wow.
Well, there's emerging evidence that low-magnitude whole-body vibration can actually have positive effects on bone. For instance, helping reduce bone loss in postmenopausal women, maybe improving muscle strength and balance. It just highlights how complex vibration's biological effects are. It's not just vibration itself, but the magnitude, frequency, duration that determines if it's harmful or potentially beneficial.
Fascinating contrast. Finally, let's bring this right back to the real-world impact for patients. How does HAVS fit into the occupational compensation landscape, especially here in the UK? And what are the ongoing challenges in getting these cases recognized and compensated effectively?
Yes, this is critical for affected workers, where the legal and medical sides meet. In the UK, HAVS is designated a prescribed disease, PDA11, under the Industrial Injuries Disablement Benefit, IIDB, scheme.
What does that mean for workers?
It means the scheme provides non-contributory, no-fault benefits for disablement caused by work-related conditions, crucial for those whose livelihoods are impacted. For compensation criteria, generally 3 things need to be met for a successful claim. 1, a history of sufficient vibration exposure. 2, clinical symptoms consistent with HAVS. And 3, no other constitutional explanation for those symptoms, linking back to our differential diagnosis discussion.
Have there been issues with defining which tools count?
Historically, yes. A big challenge was the narrow, tool-specific lists used for compensation. Early on, it might have only covered, say, chainsaws and forestry. Many legitimate cases were missed. But the Industrial Injuries Advisory Council, IIAC, has worked hard to broaden this. They've moved from rigid lists to covering basically any handheld, hand-guided, or hand-fed powered machine that produces vibration.
So things like strimmers are included now.
Exactly. Examples of newly recommended tools include strimmers, hedge trimmers, concrete pokers, life blowers, reflecting a more modern understanding of risks. A key difficulty, though, is that robust epidemiological evidence for many newer tools is often lacking. So decisions on inclusion often rely on expert opinion, alongside guidance on likely vibration levels for unfamiliar tools.
What other challenges exist in the compensation process?
Well, there are persistent challenges in exposure assessment. It's notoriously hard to precisely assess vibration intensity, duration, cumulative hours, years, intermittency. This is often complicated by worker recall bias. Employees might tend to overestimate their trigger time, actual time using the tool, while employers might underestimate it. One study found employees overestimated by 2.5 times, dental hygienists by 3 to 8 times. Huge margins of error. This really highlights why employers need meticulous records of tool use.
And people sometimes delay making claims.
Yes, we see a notable latency in claims. Claimants often delay filing. One study in British Columbia found a median delay of 6 years for loggers versus 3 years for mechanics. This delay often means that when they do file, workers are presenting with severer symptoms, which further complicates treatment, prognosis, and makes rehabilitation and returning to work much harder.
So what's the key for medical assessors involved in claims?
For medical assessors, it's vital to combine that thorough clinical history with a detailed occupational history. Recognize that HAVS is a more or less conditioned condition. There's no absolute clear-cut threshold of exposure. And individual susceptibility varies hugely. So assessors shouldn't rely rigidly on fixed thresholds of vibration level or years of exposure. They need to assess each case individually, looking at the clinical picture in conjunction with the full historical context.
What a truly comprehensive deep dive into HAVS. Professor Ma Imam, thank you so much for guiding us through this complex but absolutely critical area of occupational health. It's clear this condition demands our attention not just for the physical impact, but for the profound effect it has on a worker's whole life. For our listeners, what's one key takeaway or perhaps a provocative thought you'd like to leave them with regarding HAVS?
Well, this discussion really underscores an important question, I think. While we've talked a lot about HAVS as a direct hazard from powerful vibrating tools, maybe consider how seemingly minor daily ergonomic choices, how a tool is held, the briefest exposure to cold, how these can collectively weave this complex tapestry of cumulative damage over years. It invites us to consider the profound, often unseen link between everyday habits, even outside the obvious industrial settings, and long-term health. It prompts us to see preventative measures not just as compliance, but as fundamental investments in a worker's entire life and livelihood. The long-term impact of seemingly small exposures can be truly devastating.
Indeed. A powerful reminder that prevention is absolutely at the heart of managing this condition, and our role includes educating patients on even those small daily factors. If you found this discussion valuable today, please do take a moment to rate and share the Deep Dive Ortho with your colleagues. Your feedback really helps us continue bringing you these in-depth conversations and insights. Thank you for joining us.